I'm excited to talk to you today about your eyes and what happens to your eyes as you get older, okay? I want this to be pretty informal. There'll be times where I'm going to stop and ask if anyone has any questions, but if you have questions any other time, feel free to just raise your hand, okay? This is just going to be an informal conversation. So for those of you, can we get the lights in the front here maybe? Maybe you can see this a little bit better. So for any of you who have had an eye exam before, you'll be able to relate with this lady here on the cartoon. She's trying her best to read this eye chart. And the eye doctor's up there saying, "No, I'm sorry, you cannot buy a Val, and please stop calling me Vanna." So for all you Wheel of Fortune fans out there, I think they still play that movie, don't they? They still play that on TV, right? Yeah. So anyway, so today what we're going to talk about is 3 conditions. You've probably all heard of them at some point or another, and they're very common. These are probably the 3 most common things that we deal with as people get older. One of them is normal, happens to everybody without exception, and that's a cataract. The other 2 are abnormal parts of the aging process. They don't happen in everybody. They're very common, but they're not normal, and that's glaucoma and macular degeneration. So we're going to cover each of these. All 3, all right. We got some with all 3 up here. Okay, so first we're going to talk about cataracts. So this is a picture of our eye, cut in cross sections so you can kind of see the internal structures. We all have a lens that sits right behind our pupil here that's responsible for focusing all the light that enters the eye onto the retina so you get a clear image. When you're young, that lens is basically clear, and the light has no problem passing through. But as you get older, that lens turns cloudy and it hardens. And that's what a cataract is. So it's your natural lens, it's just turned cloudy, like a dirty window. As you can imagine, the light eventually, as this gets worse and worse over time, the light has a harder and harder time getting through that cataract, and it makes things blurry. Also, as the light comes in, it gets scattered by this cataract in different directions, which leads to glare. Glare is most noticeable at night in dark conditions because your pupil naturally dilates to let more light in. Well, more light coming in to the cataract means more light getting scattered by the cataract. And so that's why glare is often worse at night. So you're out there trying to drive, bright headlights are coming towards you, and instead of looking like nice round lights, they look more like starbursts, and all the lights kind of run together. That's glare. So these pictures are just to kind of try to simulate what you might see with cataracts. Notice first with the blurry vision you get from a cataract, you can still see most of the letters on this chart. It's not that you can't see them, it's just they don't look clear. It almost looks like you're looking through a veil or a dirty window. Okay, that's what cataracts do. And then here's a good picture of glare. Headlights coming towards you, you're getting the starburst effect. Does anyone know what I'm talking about with that? Okay, good. All right, so we're going to just talk about a few facts about cataracts. Some of these you may know, some of them you may not. Number 1, if you live long enough, you will get a cataract. That is a fact of life. And if you're surprised by that, don't feel bad. I've had doctors who've come in for eye exams and we've told them they had a cataract and they were astounded. I have a cataract? Of course you have a cataract. You're over 55. Oh, I didn't know everyone got cataracts. Of course everyone gets cataracts. It's a part of the normal aging process. So anyone in this room who's over 55, unless you've already had your cataract removed, you have a cataract. All right? Number 2, most people who have cataracts don't know they have them. And that's because when they start to form, they do so very slowly and very gradually. And so you don't get symptoms for many, many years usually. Most people start to develop cataracts in their mid-50s, but they don't start to cause a visual problem until your late 60s or even early 70s. Okay? Number 3, all cataracts get worse. They don't stay the same, they don't get better. They go in one direction only, downhill. They get worse. How quickly they get worse is different in different people. Some people, they'll get worse quicker and have to be addressed, and other people it takes years and years. Number 4, there's nothing that can cause a cataract to disappear or go away once it's formed. The only way to fix a cataract is to actually remove it, get that cloudy lens out of there. Okay? So a few more facts. Nowadays, everybody who has a cataract removed from their eye also has an artificial lens implant put into their eye at the same time. A lot of people don't realize that. If you have a cataract removed, you will get a lens implant. This didn't used to be the case, and we're going to talk about that a little bit. If you did not have a lens put back in your eye, you would need really, really thick glasses, like Coke bottle glasses, in order to see. That lens in your eye is very important in bending the light so it can focus on your retina. And when you remove that lens, you remove that bending of the light, and you have to put something in there to rebend the light in order to see well. So number 6, nowadays lens implants that we put in, they're not just run-of-the-mill, every person gets the same type of a lens implant. They're customized for you, and we can customize them in many different ways, and we're going to talk about some of those ways. Number 7, cataracts do not grow back. So once you have your cataract removed, it's done. It's not going to come back again. Okay? And then number 8, most people who have cataract surgery will still need glasses in some form to get their best vision after the surgery. It may only be for distance, or it may only be for up close, or it may be for both. But most people will still need glasses. You know, everyone has a neighbor or a relative who had perfect outcome after cataract surgery, doesn't need glasses ever again. Although that does happen, that is the exception, not the rule. Most people will still need glasses in some form. Yes?
So would you ever need to have that lens replaced that they put in after cataract surgery?
It's a great question. So her question is, after you have the lens removed and the artificial lens put in, does that artificial lens ever have to be replaced? It's a great question. We get that question a lot, and the answer is no. That lens stays in your eye. It stays clear for the rest of your life. We have patients who are, although it's rare, we do have young people sometimes that develop cataracts. We can put a lens in a 30-year-old, and it will be good until they're 80 or 90 years old. The lenses don't go bad, thankfully. All right, so what I want to do now is just kind of go over with some pictures in general how a cataract is removed. Nowadays, we use a process called phacoemulsification. Phaco refers to the use of ultrasound energy to emulsify the lens. So we use a little probe that looks like a pen. It's not much bigger than the diameter of a pen. And it goes through the front of the eye. We use that to break up that cataract into pieces. That ultrasound tip vibrates extremely quickly. And the ultrasound energy that's produced breaks this lens up into hundreds, if not thousands, of tiny little fragments, and we just vacuum those fragments out. Once the cataract is all removed, you then have an empty bag or capsule where the cataract once was, and we then take a lens implant and we slide it right in there, and it takes the place of your natural lens. So after the surgery, you've basically traded your cloudy lens for a clear artificial lens, and the light can now get through unobstructed again. Okay? So what I want to do now is talk about one of the most interesting things about cataract surgery is how much progress we've had in the field of cataract surgery in such a short period of time. I think you'd be hard-pressed to find any field in all of medicine that's had as much evolution in a short period of time as cataract surgery. Back in the day, this is prior to 1950s, when they removed a cataract, they had to take it out in one piece. They didn't have a method to break it up into smaller pieces. So they would make a massive incision, almost the entire length of the eye, so that they could take this lens out in one whole piece. Okay? And then it left them with this big gaping incision that they had to put lots of stitches in to get it to close. And those stitches induce astigmatism, they cause pain, and they cause all sorts of problems. And early on with cataract surgery, they didn't have lenses to put in the eye. They didn't know you could put a lens in the eye. So these patients were left without a lens, and everyone needed glasses. You could always tell who had cataract surgery because they're the ones who had those thick Coke bottle glasses. Okay? Current cataract surgery, in contrast, we use micro-incisions. The incision that this ultrasound probe goes through is 2.4 millimeters. and sometimes even smaller, 2.4 millimeters. That is extremely small. And again, we do that, we're able to do that because we break the cataract up inside the eye into small pieces. And then when we put your lens implant in, it actually goes in folded up in half like a taco. It gets inserted and then it unfolds within the eye. So that way we're able to put it through a very small incision, let it unfold in the eye, and then we put it into position. So it's pretty interesting how they figured out that you can actually put a lens in someone's eye and leave it there. Because in general, you think about putting a foreign body anywhere in someone's body, and it's not a good idea. You don't want to leave something foreign in someone's body. Well, this guy here is a hero of mine. His name's Harold Ridley. He was an ophthalmologist in Britain during the time of World War II, and he was asked to take care of a lot of the pilots that sustained eye injuries during World War II. And he noticed an interesting observation. So he had a lot of people coming in with eye injuries and fragments of material in their eyes. What he noticed is that patients who came in with acrylic splinters from like the canopy, the cockpit canopy of the plane, they didn't have an inflammatory reaction in their eye like the people who came in who had glass in their eye did. And so it got him thinking, maybe we could put a similar material in the form of a lens in the eye, and it would be safe. It wouldn't cause inflammation. And so he pursued that, and he actually implanted the first lens in 1950. That was over in Britain. The first lens implant in the U.S. was in 1952 at a place called Wills Eye Hospital in Philadelphia. And that's actually where I did my training. So I'm kind of proud of that fact. That's pretty cool. But again, so you look, and back in 1952 when they were implanting these lenses, they had no idea, what materials to use, whether the same lens should be used for everybody, what strength that lens should be. And so people initially had refractive results all over the place. They needed glasses. They had all sorts of issues that needed to be addressed afterwards. Fast forward just a little over 50 years later, and we now have customizable implants. We know which measurements to take. We know how to do the calculations. We can get most patients within a very, very small margin of error of where we want them to be. And we can pick where we want them to be based on what they want. We can focus them for near. We can focus them for far away. We can focus them in between. We can focus them for all three if they want. There are options available for all that. It's pretty incredible how much it's advanced. So some of the ways it's advanced. So number one, we now have customizable lens implants. This is what the lens looks like that we put in your eye. Now just keep in mind, this is not actual size. We don't put that in your eye. But this is what it looks like. It's got a round center and then these two little arms that help hold it into position. And then this lens has a power to it, and we customize that for each person. Each person who has cataract surgery has customized measurements taken of their eye so we can pick the right lens. Not only can we correct nearsightedness or farsightedness that you may have had before cataract surgery, but if you have something called astigmatism, which a lot of people do, that just means your eye's not perfectly round. We can also correct astigmatism at the time of cataract surgery with special lenses. We have to line these markings up with the axis of your astigmatism, and it can correct it. So a problem that somebody's had their entire life that required glasses, astigmatism, we can correct that at the time we put this new lens in. They also have what we call multifocal lens implants. So the standard lens that we put in is called a monofocal. Mono meaning one, focal meaning one focal point. We can focus you at one distance, whether it's far or close up. But then you got to use glasses to see the other one, okay? Multifocal lens implants do just that. They give you multiple focal points so that you can see distance, intermediate, and near without the need of glasses. So if you know somebody who had cataract surgery and no longer needs glasses to see anything, chances are they probably had a multifocal lens implant put in. Yes?
Yeah, I've got that.
Oh, you've got that. There we go. And? Okay, all right. So all right, so one of the more recent advances in cataract surgery is that we now have lasers that can help assist us in certain parts of the cataract surgery. This is pretty cool, and this is very, very recent. This just came on the market within the last couple of years to use a laser to help with that. This offers us more precision in what we're doing, and also requires less ultrasound. Remember, we're using ultrasound energy to break up that lens and to emulsify it. Well, the more ultrasound energy you use to get a cataract out, the more damage it can cause to the surrounding tissues. So in general, if the less ultrasound you have to use, the better. The laser helps us so we can use less ultrasound energy. It's less traumatic, so it just makes it even better. Now I have here a video that I want to show you that I think helps explain much better than I could. It's going to take you through the standard procedure for a cataract removal, which I think is interesting, and then it's going to take you through how the laser can assist us with this, okay?
Cataract surgery involves corneal incisions, capsulorhexis, a circular hole in the capsular bag, lens fragmentation, phacoemulsification, intraocular lens insertion, and incision closure. The LensX laser can assist with some of the most challenging steps. Standard cataract surgery starts with the creation of an incision through the cornea, utilizing a scalpel in order to allow the surgeon access to the cataract. LensX provides customizable laser precision and reproducibility in the creation of the incision. Capsulorhexis is the medical term used to describe the removal of the outer layer of the lens in order to allow the surgeon access to removing the cataract. This is the single most important step in your visual outcome. In standard cataract surgery, this step is performed by the surgeon manually creating a circular opening with a handheld instrument. LensX laser offers your surgeon laser precision to create the circular opening and allows the lens placed to have the best possible effective lens position. This allows the patient to experience the most predictable post-operative visual results. Standard cataract surgery requires a phacoemulsification machine to segment and remove the content of the cataract. The goal of your surgeon is to reduce the amount of phaco energy used to remove your cataract. The LensX laser performs lens fragmentation, creating easily dissected segments for efficient removal with little or no phaco power. With the laser pulses utilized, the LensX laser provides the surgeon 43% reduction in phaco power and 51% reduction in phaco time compared to the standard cataract procedure. LensX laser refractive cataract surgery offers a new level of precision and reproducibility in ophthalmic surgery.
Okay, so hopefully that made sense. I saw that movie and I thought it was just a really good summary to show you kind of the process of removing a cataract, and now we have lasers that can assist, which is just really cool. Yeah?
Is this the process you guys use then?
Not for everybody. The LensX laser, as you can imagine, it's an additional cost from standard cataract surgery. In some people, it's strongly recommended if they have really, really dense cataracts, and we think we're going to have a really difficult time removing it with ultrasound alone. Oftentimes we'll recommend doing this. Or there are other conditions with the eye that make it more risky, and in those patients the laser is definitely recommended. But in general, we still use just the standard phacoemulsification most of the time.
Okay, so then if you have a cataract and you do not have it removed, what are the, should you not? Is there...
What will the impact be?
Yeah, so great question. So the question is, if you have a cataract and you decide not to have it removed, what's the result? What's going to happen? Well, so cataracts, they'll just continue to slowly get worse and worse and worse over time. Eventually, you start to lose vision. A cataract can cause you to go blind, eventually. Now, with that, we're talking waiting an extreme amount of time. Like, it would take, into your 80s or 90s before the cataract gets bad enough to cause you to go blind in most scenarios. It's also important to realize that cataracts, they can get to the point where they become so dense that they become difficult to remove. It becomes like a little rock inside the eye. So when we're in there trying to break it up into pieces, it won't break up, it's too hard. And it puts you at a higher risk for complications during your surgery. So in general, we don't take cataracts out when they form because they're not causing a problem. The best approach for cataract surgery is rule number one: if it's not broke, don't fix it. If you're not having any symptoms, you're doing fine, doing all your activities that you need to do, we don't mess with it. But rule number 2 is as soon as it's broke, then fix it. Okay, once you start to have a problem from your cataract, that problem is only going to get worse. And so once it's causing an issue, that's the time to take it out, while it's still soft enough to be able to get to and to take it out safely. So what you don't want to do is be like this gentleman who came in to his wife made him come in because she was worried his cataracts were getting worse and that he wasn't seeing very well. But he came in, he wasn't having any problems. He was feeling good, said he could do everything he needed to do. He wasn't really bothered by it, so he decided not to have anything done. Well, one day his wife, he was getting out, ready to go out and run some errands, and his wife said, be careful when you're driving, make sure you're safe, don't take any unnecessary risks. So he's not gone more than 5 minutes, and the wife turns on the news, and she sees, and she calls him immediately. She says, hey, I just saw on the news, there is a driver on the freeway that you're on going in the wrong direction. You be careful, watch out for this person. And he said, oh honey, it's much worse than that. There's not just one, there's hundreds. So you don't want to be like that guy. And that's actually not a true story, it's just a little joke. Okay, do we have any questions about cataracts before we move on to glaucoma?
What does the term "it's right"? Does that have any significance?
Yeah, that's actually, so the question is, she's asking about the term "it's ripe," the cataract is ripe. And that's something many people have been told. We actually get this question all the time. All that means is kind of what I just explained. You don't want to take a cataract out if it's not causing a problem. If somebody's 55 years old, starting to get a cataract, just because you have a cataract is not reason to take it out. If you're not having problems, then you're taking unnecessary risk. Because even though most cataract surgery is very successful, there's still risk involved. It's still surgery. So whenever you're doing anything in medicine, you want to weigh the risk versus the benefit. If you stand very little to gain, if you're 20/20 and having no problems, you stand very little to gain by having that cataract removed at that time. But later on, once it's starting to cause a problem, then you stand more to gain. You're willing to take on the little bit of risk that's there. So by the term ripe, it just means we don't take it out before it needs to come out, but we also don't unnecessarily put it off until it's too dense. So, yeah. All right, any more questions about that? Okay, so glaucoma. So glaucoma is a condition that affects the optic nerve. The best way to think about the optic nerve, it's like a big cable that carries all the information from the eye to the brain. So it's pretty important. If your nerve gets damaged, you're going to have visual problems because all the visual information is being carried by that. In glaucoma, what typically happens is pressure builds up inside the eye and it basically squeezes that nerve and causes the fibers that make up the nerve to die very slowly. The best way to think about the eye in terms of glaucoma that I like to explain it is think of a bathtub where the tap is turned on, so water's coming into the bathtub, but the drain is left open. So what happens? If the inflow equals the outflow, you're fine. That bathtub it's never going to overflow. But what happens if you have a bad drain and the drain's not working well? Well, slowly that water's going to build up and start to overflow. That's kind of what happens in glaucoma. Your eye is constantly producing fluid, this structure called the ciliary body, and that fluid flows forward in front of and through the pupil, and then it comes and it drains in this little hole, this little canal here, that runs all the way around your eye. There's different types of glaucoma, and I'm not going to get into that. The most basic type of glaucoma that most people have is a condition where the drain doesn't work. So it's like your bathtub that's clogged. The eye is still producing fluid, but it can't drain out adequately, and so the pressure builds up. When the pressure builds up, it squeezes the nerve, and the nerve dies slowly. Does that make sense, kind of? So this is a picture kind of what happens with glaucoma. If you look down here in the bottom right, this is normal vision. You can see in the center, you have good peripheral vision, you can see off to both sides. As early glaucoma starts to take your vision from the outside in, very slowly. So you can see early on, barely detectable, but you can see some difference here. It's starting to darken here. More advanced glaucoma, starting to see less and less in the periphery. Extreme glaucoma, you can't see really anything in the periphery. Here's the scary thing about glaucoma. This person comes into the clinic, gets a vision test. Their vision is 20/20. Guess what this person's vision is who comes into the clinic? It's 20/20. You can have advanced glaucoma and still have, quote, perfect vision, which is 20/20. Unless somebody screens you with a peripheral field test, they may not even pick that up. Okay? So that's what's scary about glaucoma. You know, you may look at these pictures and say, oh, I would totally notice if I went from this to this to this to this, I would totally notice that. I'm not going to let that pass me by. But no, it happens so slowly. This represents years and years of progression. And it happens so slowly that people do not notice it. And that's why glaucoma is scary. It's called a silent disease because you can be getting worse and progressing and you have no idea, no clue at all. All right. Has anyone ever boiled a frog? I know it's a weird question, but okay. Has anyone ever tried to boil a frog? You've all heard this analogy, right? If you put a frog into a pot of boiling water, what's it going to do? It's going to jump out. If you put a frog in a pot of cold or room temperature water and turn on the burner and let it slowly heat up, what does the frog do? He'll stay in there until he dies. Or she. I guess I shouldn't assume it's a guy frog. Because he's doing something stupid, I'm assuming it's a guy frog. But could be a female frog. So here, yeah, you have this frog here. This one's already kind of kicked the bucket. And this one's saying, this is the life. I love a good soak. And then down here it says, attention, when boiling a frog, place in cool water and slowly turn up the heat. So cataracts are like boiling a frog. And so is glaucoma. These things happen so slowly that they're almost imperceptible, and you don't really notice that it's even happening. So a few facts about glaucoma. So glaucoma is the leading cause of blindness in the United States. So that should get your attention. It's pretty common. We see a lot of this stuff. And this is especially impressive because, as you're going to see later on, glaucoma is completely treatable. We can prevent vision loss from glaucoma. So the fact that it's the leading cause of blindness in a country like the United States, where we have access to great medical care in almost all places, it means that people just aren't getting screened and just aren't getting this picked up. Number two, again, the main problem with glaucoma is that the nerve of the eye gets damaged. We talked about that. Number three, the eye pressure is usually, but not always, elevated in glaucoma. So we used to think that high pressure equaled glaucoma, and that's what it was. But we now know that that is not the case. It is possible to have a high eye pressure and not have glaucoma. It is also possible to have a normal pressure and still have glaucoma. So sometimes people go get their eyes screened and they get their pressure checked and their pressure is good and normal, and they say, oh, I'm good, I don't have glaucoma. Well, that's probably a good general rule most of the time, but not always. It all depends on how sensitive your nerve is. Some nerves can tolerate a pressure higher than normal and not get damaged. Other nerves can't even tolerate normal pressures. And so it really is kind of an individualized thing. When we're treating somebody with glaucoma, we have to look at them and all of their tests and everything together and try to decipher what pressure is good for them, for that individual. Number four, again, just to reiterate, vision loss happens very slowly from the periphery inward, and it's so slowly that it's imperceptible, mainly because it spares the central vision. People can still see well straight ahead, so they assume everything else is okay. Just a few more facts. And this one is unfortunate. There are very few symptoms from typical glaucoma, other than that slow vision loss. But as we talked about, most people don't know that's going on. So what does that mean? It means that you can lose vision from glaucoma and have no idea. You don't get a red eye usually. You don't get pain. You don't get discharge. You don't get floaters. You don't get anything from normal run-of-the-mill glaucoma. Number six, this is also unfortunate. Once the nerve tissue is damaged and once those small fibers die, you can't get them back. What's done is done. All you can do is prevent further vision loss. So that's our goal in glaucoma. Our goal is not to restore vision. Our goal is to preserve vision and prevent you from losing more. That's why it's important to be screened and detected early. If you detect glaucoma early, there's not a problem. You'll live the rest of your life with in most cases, with very little to no vision loss and do very well. So, number seven, It's possible to prevent significant vision loss from glaucoma, okay? And number 8, if it's uncontrolled, glaucoma can lead to complete blindness, where you see absolutely nothing out of the eye, which is in contrast to what we're going to talk about next. So, real quick, just to kind of give you some idea, this is what the nerve kind of looks like when we examine your eye. Everybody's nerve has a little depression in the center called the cup. That cup should be about 1/3 of the size of the overall nerve. So if you divide this into 3 sections, that cup, that depression takes up about 1 out of 3. It's about 1/3. That's normal. What happens in glaucoma is that cup gets bigger and bigger. So if you look here on this side, this is a normal nerve. So here's your nerve, and you can see the little depression in the center. Again, it takes up, if you divide it into 3, it takes up about 1/3 of the nerve, or even a little bit less. That's normal. If you look over here, this one, the cup is so large, it almost takes up the whole nerve. And the cup is not what's so important, but this rim of tissue is what's important, because as that cup gets bigger, your rim of tissue gets less and less. And once you lose tissue on the rim, that's when you lose vision. Okay? So if you look at this person here, so this person definitely probably has some glaucoma going on. If not, then we're watching and we're strongly suspicious for glaucoma. But because their cup is big, their rim is very thin. But you can see they still have rim all the way around. This person probably has no vision loss yet from glaucoma because they still have rim all the way around. In contrast to this person where there's no rim. This is basically all the yellow cup that's right there. This person has severe end-stage glaucoma on the right. So what do we do about glaucoma? Well, there's really only one thing that we can do, that we know how to do, and that's to lower the pressure of the eye. Lowering the pressure to a safe range where you're not getting damage. And again, that's different for everybody. We can't just pick an arbitrary number and say we're going to make everyone's pressure this number and they'll be fine. We have to look at each person and find a pressure where they're no longer getting worse, and that's the pressure that's okay for them. There's 3 different ways to lower the pressure. There's eye drops, there's laser, and there's surgery. Surgery is a last resort. We don't do surgery unless the other 2 fail. But eye drops, there's a lot of good eye drops, a lot of options available, and most people do really well with eye drops. One of the eye drops we put you on is once a day. That's pretty easy, not too disruptive to your lifestyle. Some of the drops are twice a day. But still, even at that, twice a day to preserve your vision. So a lot of people don't get checked for glaucoma because they don't want to have to be on drops and all this stuff. But in the end, losing vision versus putting 1 or 2 drops in a day, it's a pretty good deal if you can control it with eye drops. Laser is another good option. Just do a little in-office laser procedure that's painless, but that can often lower the pressure to safe levels as well. So the point is there's lots of options available for glaucoma to treat it. So there's no reason why glaucoma should be the leading cause of blindness in a country like the United States. We should be able to screen for this, pick it up early, and prevent vision from being lost. So, all right, any questions about glaucoma before we, yeah?
As you take the eye drops,
Yeah.
or do the laser,
Uh-huh.
or do the surgery, does the cup reduce?
Great question. Yeah, that's a great question. So she said if you're getting laser or using drops to treat your glaucoma and the pressure goes lower, will the tissue of that cup decrease? Will the cup size go down? And the answer is no. And that's the principle of once those nerve fibers are lost, you can't get them back. And so that's why it's much more important to catch somebody in the early stages before they've already lost a lot of those fibers, because once you've lost them, you can't get them back. With surgery, laser, or anything, doesn't matter what you do, nothing you can do. So, any more glaucoma? Yeah.
How often should you be screened for glaucoma?
Yeah, another great question. So, anyone who's over the age of 55, we know you have a cataract. We know that the risk for glaucoma and macular degeneration that we're going to talk about next both go up with age. They're much more common in the older population than in the younger population. Because at age 55 we know you at least have a cataract, we recommend getting an annual eye exam starting around age 55, and then that way we can monitor your cataracts, and every time you come in we're checking your pressure, we're looking at your nerves, and we're screening you essentially for glaucoma and macular degeneration. If you have anything that looks suspicious for glaucoma, then oftentimes we'll see you more frequently, twice a year or maybe even 3 times a year. But that just kind of depends on what we find. So, yeah.
Is it hereditary?
It is. Yep. So one of the questions I ask people, if I see anything that looks suspicious for glaucoma, let's say their pressure's higher than it should be, or let's say their cup is bigger than it should be. One of my first questions to them is, tell me about your family. Do you have any family members who have glaucoma? And if they say, oh yeah, my mom had it, my grandma had it, my aunt has it, that already raises my level of suspicion a lot, and I'm watching them a lot more carefully.
My uncle has it, and that's why I asked.
Okay, yeah. So on the flip side though, just because a family member has it, just because it runs in your family doesn't mean you're doomed to get it. You know, you may not get it.
But should I be checked more often?
Just as long as you're being checked every year. If your doctor is concerned in any way about glaucoma, they'll direct you. And they'll say, I want to see in 6 months or 3 months, whatever it is. As long as you're getting checked every year, that's adequate. Yeah.
Then I have glaucoma. Would my boys be susceptible to it?
Yeah, so the question is, if I have glaucoma, would my children, my boys, be susceptible to it? And the answer is yes. Yeah, they would. So again, glaucoma, it can happen in younger people, but it's extremely rare to see glaucoma under the age of 50. So if someone has a family history of glaucoma, maybe having one exam, you know, when you find that out, if they're in their 30s or 40s, just to check if everything looks good, then, you know, still probably wouldn't need annual exams until about age, you know, till 55-ish, in that range. Yeah.
Is there anything to take beforehand so you don't get it?
I wish. I wish there was. I really do. That would be awesome. But no, there's really not. There's no diet changes you can make. The only thing that's really been consistently shown to lower your eye pressure is exercise. It's consistent, but I mean, exercise helps everything, right? It's the thing that helps everything, but none of us want to do. But so, unfortunately, so. Okay, yes.
Is the glaucoma test that little air poof?
Yeah, so, yes, the air puff, it used to be. So many of you are familiar with that air puff, okay? Where and I had another cartoon, I should have brought it. It's got a picture of a patient on their chair, lying on their back on the ground. And the technician is saying, hey doctor, I think the glaucoma machine needs to be calibrated again. It had knocked the guy over. And we get that question a lot. You're not going to do the puff of air, are you? And no, that is not the standard way to check pressure. The air puff is not as accurate. It's used a lot, like at health fairs and stuff like that, to screen, because you don't have to touch the eye. And so an untrained technician can do that. The way we normally check pressure is we flatten the cornea. The cornea is kind of curved like a ball, and we flatten the cornea. And the amount of force that it takes to flatten the cornea correlates with the pressure inside the eye. That's the best, most reproducible way to check the pressure, and that's how we do it in the office. We don't even own the air puff machine. But if you're getting your eye pressure checked at like a health fair, you're probably going to have the air puff, just because it's a way for them to at least get a rough estimate by someone who's not fully trained to do the full thing. So it still has its role to pick up any problems, but it's not as accurate. So, all right. Well, let's touch on macular degeneration briefly. So, macular degeneration is a condition that affects the macula, believe it or not. The macula is the center part of your retina. So the retina is like an orange piece of wallpaper that's stuck up against the back of your eye. The retina goes from almost the front of the eye all the way around the back and to the front again. Most people don't realize the retina covers that much ground, but it does. There's a lot of retina. The macula is this area right in here, just right in the center. That just happens to be when the light comes in, that is where that light focuses, is right on the macula. So it's responsible for your best, your central, your fine detail vision, okay? So the unfortunate thing with macular degeneration is this area of the macula starts to degenerate. You develop little deposits there called drusen, and the retina starts to thin out, and you lose some tissue there. But if you look for macular degeneration, 90 to 95% of your retina is still okay. It's just unfortunate that it's the 5% that's the most important that degenerates. So that's why macular degeneration is so unfortunate. It's a problem that's caused in just the wrong spot. So
Is that above the nerve, or is that up?
it's to the side of the nerve. Yeah. Hard to tell from that picture because it's 2D, but the macula is to the side of the nerve. Yeah. So this is a picture to try to illustrate what macular degeneration might look like. So think back to glaucoma. Vision loss from macular degeneration is basically opposite of glaucoma. So glaucoma starts from the outside in, you lose peripheral, but it spares your central vision until the very end. Whereas macular degeneration, the only thing it takes is your central vision. Peripheral vision is fine. So you'll maintain that. So it's, you know, you can see this, but you just can't see what's in the middle. So you can see a clock, you just can't see the face of the clock. You can tell it's a clock, you just can't see the time. So many of you who have had eye exams have seen this. This is called an Amsler grid. One of the things that that problems in the macula cause is they cause straight lines to become curvy. So this is an Amsler grid where all these lines are straight and parallel. And they do look a little distorted, I'll give you that, so don't freak out. I was showing this to my wife and she's like, well wait, these look a little wavy to me. And I was like, it's okay. The page I took these from was kind of bent when I took the image, so they look a little distorted. So I'm not diagnosing anybody today, you're fine. But, so these should all look straight and parallel. When you have a problem in your macula, like macular degeneration, those straight lines start to look warped or curvy or wavy like that. Yeah.
That black center that you showed, I have that, it happens only at night after I go to bed and I take my glasses off and I look up, there's big black spots there and it moves,
That's my
but it isn't there in the daytime. Is that?
So yeah, so that's something else. I mean, macular degeneration doesn't change, doesn't fluctuate. Yours could be something like a floater or something that's there sometimes and noticeable in certain conditions, certain lighting conditions, but not in others. But would not be macular degeneration. So yeah, so. All right, so a few facts about macular degeneration. So macular degeneration is the most common cause of severe vision loss in people over 50. So I don't want to confuse you. Remember, for glaucoma, we said glaucoma was the leading cause of blindness in the United States. Well, macular degeneration doesn't cause blindness. Okay, that's point number 2. It does not cause you to go completely blind and does not affect your peripheral vision. So most people who have macular degeneration will still be able to use their peripheral vision and still will be able to do a lot of activities of daily living. If it gets to a certain point, they're not going to be able to drive because you lose that center vision. You don't meet the driving criteria, but you can still get by and do a lot of your activities still with macular degeneration. You never go completely blind from it, in contrast to glaucoma where you do, if it gets bad enough. Number 3, there are 2 forms of macular degeneration, and maybe some of you have heard of these. There's the wet form and the dry form. And we're going to talk a little bit about those, what the difference is. Major risk factors for macular degeneration, the 3 biggest. There's lots of smaller ones, but the 3 biggest are age over 50. In fact, the name of this is age-related macular degeneration. That's the full name, age-related macular degeneration. If you're looking at somebody's eye and they're less than 50 years old, and you think they've got macular degeneration, you better rethink your diagnosis because they're less than 50. We almost never see this in people under the age of 50. It's probably something else that looks like macular degeneration but isn't. It's that specific to the older generations. So age over 50 is risk number 1. Number 2 is a family history of macular degeneration. So again, just like we talked about with glaucoma, macular degeneration can run in families. It doesn't mean you're doomed to get it if your parents had it, but if you have a family history of glaucoma, not a bad idea to get checked to see if you've got early beginnings of it. Okay? And then the 3rd risk factor is smoking. So just like exercise makes everything better, right? Smoking makes everything worse, including macular degeneration. So, yes?
Question, I had heard something about if you're fair-eyed, fair-skinned. Is that accurate?
It can be. So in general, I mean, UV exposure and things like that can cause cataracts to get worse. They can be worse for something like macular degeneration. Someone who's fair-skinned and light-eyed is more prone to exposure to UV. They get more exposure than the average dark person who has more pigment. So yeah, but in general, if you're fair-skinned and blue-eyed, it doesn't mean you're going to get macular degeneration by any stretch. But it's one of those smaller kind of risks that we talked about. That's, yeah. Okay, so a few more facts. So dry macular degeneration. So this is a picture of dry macular degeneration where you develop these kind of deposits that just start to collect underneath your retina called drusen. And normally this should look all smooth and regular, but you can see here it's just not. 90% of people who have macular degeneration have the dry form. So this is by far and away the most common form of the disease. And vision loss with this is usually gradual. In fact, I will tell you, most people who have dry macular degeneration don't even know they have it because it's not causing any visual symptoms yet. Okay? And often, these patients will often have difficulty adjusting to changes in lighting. So going from a dark room to a light room or vice versa can take you longer. Now, macular degeneration is not the only cause of that. So if you have a hard time adjusting to lighting changes, don't assume you have macular degeneration. I don't want to scare anybody. But that's just one of the problems that they commonly have. The wet form is much different. So in the wet form, you get a network of new blood vessels that starts to form underneath your retina, and those blood vessels break spontaneously. When they break, they leak blood and fluid and protein that's normally in your blood system. That's where the term wet comes from. That's what's wet in the wet macular degeneration is blood and fluid and things that leak from your vessels. And so you can see here in the macula, they have all this blood and fluid that's collected there. So again, much less common, 10% of people with macular degeneration have this. Even though that sounds pretty rare, 10%, because it's so common, we see a lot of people with wet macular degeneration. So it's out there and it's pretty common. Usually people with wet macular degeneration have more severe vision loss than dry, as a general rule. Vision loss can be rapid and severe. Once those blood vessels break and it starts to bleed, you can get rapid vision loss. And oftentimes we'll give one of those grids that I showed you earlier to each patient with macular degeneration to check themselves at home so they can monitor. And they should check it every couple few days. And if they ever noticed a sudden change in the waviness of those lines, we have them come in. That can often be the best way to pick up macular degeneration that's turned into the wet kind. So, but the good news is vision can be maintained with injections of medication into the eye. And this is a very recent development. It used to be if you had wet macular degeneration, it's kind of a, sorry, I wish there was more we could do, but there's not. People would just progressively lose more vision. We could never get vision back and we could never halt the process. Nowadays, with these medications that came onto the market around 2005-ish, so they've been on the market for about 10 years, we can improve macular vision in macular degeneration, and we can maintain it oftentimes. Now, sometimes it takes injections on a monthly basis, and if you know anybody who has macular degeneration, they'll tell you they probably hate coming in every month. But when you consider the alternative of vision loss and not being able to see, it's a price worth paying to come in every month to have that taken care of. So this is something, we get lots of questions about this, okay? So vitamins and minerals for macular degeneration. So this is all based off of two studies that they did called the Age-Related Eye Disease Study, abbreviated AREDS. And then a couple years later, they retested everything, tested a couple of new different nutrients as well, and that one's called AREDS 2. So AREDS 2 data was released in 2012, and that's the most recent, most up-to-date data that we have on this. So these are significant studies. It's the only time in all of medicine, not just in ophthalmology, in all of medicine where the statistics actually proved that vitamins were beneficial. They've tested vitamins for all sorts of stuff. And there are times where they think it might help, or it seems to help some people, but the statistics, the statistical analysis has never borne that out. It's never proved it until this study. So this was statistically proven to help, which is pretty cool. But you have to know the conditions that it was tested under. So what it showed is in certain patients, and I'm going to elaborate on that in a second, the vitamins may slow the progress of macular degeneration. So notice I did not say that it stops macular degeneration. I did not say that it prevents it. And I did not say that it reverses it. It may just slow it down. Okay, it may just slow it down in some people. What I mean by certain patients is in this study, they gave these vitamins to people who didn't have macular degeneration at all, people who had mild, intermediate, severe, every spectrum. And then when they analyzed it, what they found is that patients who had moderate to severe disease had a benefit from the vitamins. It slowed down the progression of their disease. In patients who had the mild form of macular degeneration or who didn't have macular degeneration at all, there was no benefit to the vitamins. Okay? It didn't harm anything, it didn't hurt anything, but it didn't help either. So in general, we do not typically recommend that you start taking these vitamins just in case you get macular degeneration. Okay? So we typically do an eye exam, and if you've got moderate to severe, it's a no-brainer. You would benefit from vitamins, you should be on them. If you've got mild macular degeneration, well then it's kind of a discussion with you and the doctor. If you've got a family history of macular degeneration, you're really worried about it, and you've got mild disease, then I'll say, you know what, you might as well take it. You know, it's not going to hurt anything, and it may help. You've got a family history, let's just do it. Or in some people, if you have no family history, it's really mild, we may say, you know what, let's not do vitamins for now. But a lot of times it'll be left up to you. These are over the counter, and you can buy them without a prescription. Okay? My only caution is there's a lot of eye vitamins out on the market. You find tons of different ones if you go to the pharmacy. If you're looking for the right vitamins for macular degeneration, I recommend getting something that's based off of the AirEdge 2 formula. If it says that on the box, then you know that it's based off of this study, and it's going to have everything you need and nothing that you don't. Okay? Otherwise, it's hard to know what you're really getting. So in conclusion, cataracts, glaucoma, and macular degeneration are the 3 most common causes of vision loss as you age. Okay? Regular, and by regular I mean annual, eye exams can help detect and monitor for these conditions and pick them up early. And because of the advances we've had in medicine, it's made it possible for most patients, again most, to maintain functional vision if we can detect it early and start treating it. So, all right, thank you for your attention. And great, thank you for your questions. It's so much better when you're a presenter, when people actually have questions. It's awesome. So this is my family, by the way. I have to show them.